Okay, so next we also looked at pollen in exactly the same way. To disclose. And the reason that we looked into pollen is because we know from some cross-sectional studies that UCPBS is at least statistically correlated with reporting a history of allergies. And anecdotally, participants had reported to us that pollen triggered their flares. So the start of the pollen season, or maybe someone's cat, or someone brought a bouquet of flowers home or something like that. However, no studies had tested this hypothesis empirically. So we decided to take that same case crossover study that we had conducted, and we linked it to pollen data that we bought from pollen.com, because it's not freely available. So exactly the same study design, exactly the same sample size. Again, just to give you an idea of the distribution of the exposure that we had to work with, pretty much the pollen distribution was bimodal at most of our sites, so we had a peak in both the spring and in the fall. We did the same analysis looking at daily pollen levels in relation to flare onset, and we did it both in all participants as well as those who reported that they had allergies, because we thought that they might be more susceptible to pollen as a trigger. And here, again, we found no association when looking at daily levels. And then we also looked at changes in pollen level, because we thought that perhaps we might see more when we were looking at the start of a pollen jump than if we were looking sort of mid-season. And we did see a little something here, so possibly a suggestion that an increase in pollen might be related to flare onset, or at least sort of pollen levels jumping around. So here we see daily changes, and we also collapsed looking at the 2 days before a flare as well as the 3 days before a flare, and possibly some suggestion that in the 2 days before a flare started, that at least a small increase in pollen was possibly related to flare onset. And then, just like we did with the weather analysis, to get a bigger sample size, we expanded to using all of our longitudinal data, which is a little bit less precise. And for each of the zip codes that participants lived in, we identified when the pollen season started, and we looked to see whether pollen rates were higher in the first 3 weeks after that. And we found it wasn't statistically significant, but we found some suggestion that when there was a medium to high level rise, so 2 jumps in pollen, that there was a non-significant increase in flare rates. And here, just looking when we collapse over any jump in pollen level, possibly a suggestion of an association. So in conclusion, although the results were largely not significant, we did find some suggestion that increases in pollen level may trigger UCPPS flares. And just as for weather, we will pursue these further in MAP2, where we have flare app data that we can link to weather. And I just thought I'd mention this. We know we can't obviously change when plants bloom, but we did think that if we do confirm these findings, they could be important for several reasons. One, to inform flare pathophysiology, because this is very poorly understood. Possibly useful for prevention, so avoiding pollen triggers. Possibly for treatment, so some of our patients have told us that they use antihistamines to control their symptoms. And just even if there's really nothing they can do about them, it could provide them with some control over what are very unpredictable events for patients. So sort of if they know that the pollen season is about to start, sort of planning their activities around that to accommodate that. And so again, I'd like to thank the NIDDK and the MAP study for supporting this analysis. Thank you.
Thank you very much. We've got quite a few people obviously want to ask questions. Go ahead, Bill.
Thanks. Bill Gibson, Edmonton. Really interesting work. Thanks for presenting it. Could you or have you thought about looking at analysis by responder? So anecdotally, patients say that the weather sets off their symptoms. Would there be a difference in patients who believe that pollen causes them to have a flare and patients that haven't noticed that association?
Yes, that's a very good question. So when we did the study, we didn't originally design it to look at weather. So we previously published the main findings of the case crossover study where we were focused more on diet, physical activity, sexual activity, and so on. And we did have one question that we included, and we were actually more concerned about recall bias because we were asking participants to recall their pre-flare diet or pre-non-flare diet, what they thought had triggered their flares, but we did so in categories, which is unfortunate in hindsight. So we gave them a few categories. One was diet, physical activity, sexual activity, but we didn't include weather. So what we were able to do in the previous analysis is do stratified analyses, limiting it to those individuals who thought that that particular trigger had, in fact, triggered their flares. And that's where we were able to see more suggestive findings. Here, we didn't really have anything to guide us, but in the future, that would be a very important question.
Vic?
Yeah. We found that about 40% of our patients who have pelvic pain will have histamine intolerance. They have a lack of diamine oxidase. And that's treated with type 1 and type 2 antihistamines. Obviously, these patients may have had pollen, and therefore they may, as you suggest, there's some kind of symptom before the flare occurs, sort of later, sort of after the pollen flare. Is that right? But did you actually test for whether these patients then went on to use antihistamines? Because what's happening is a treatment effect. Therefore, your signal will disappear. You know how you said you had a little bit of a signal,
Yes.
and then it suddenly disappears? Well, of course, if somebody's then starting on antihistamines, they're actually starting on a treatment.
Right.
And therefore, you're not going to see a signal. You'll see the little blip,
Right.
and they start on antihistamines and they get better.
Right. Yeah, and so this study was done embedded within the broader MAP study, which had several main goals. So we sort of piggybacked onto that study design. So when I was saying every 2 weeks we asked them whether they had had a flare or not, what we were missing were intervening flares. So yeah, as you said, if there was a pollen bloom, they had a flare, perhaps they treated it with antihistamines, and then we didn't see that at the 2-week assessment. That's entirely possible, yeah. So had this been the main hypothesis that we were trying to study, we would have collected flare data every day, and it would have been more precise, yeah.
Can you just explain how you defined a flare, and did all patients feel that they reported it in the same way?
Right. Yeah, so we've done actually a fair amount of work because that was a big concern. We provided a definition for participants. I think it was, are you currently experiencing a flare of your urologic or pelvic pain symptoms? By that we mean symptoms that are much worse than usual. We've subsequently gone back to have participants fill in symptom diaries. We've done focus groups and studies and so on. We found that it tends to relate to, if we're looking at a scale from 0 to 10 in pain, that it's typically at least a 2-point change in pain. But we didn't feel, we knew so little about flares, as it turns out, when we first started the study 10 years ago, that we didn't feel comfortable imposing a definition onto participants.
It's so subjective.
Yes.
That not all patients will report it in the same way.
Exactly. And if we were to do this again, I think we would focus on pain flares, because we found that there are a small percentage experienced flares that were solely urologic symptoms. And I think we would focus, we found that when we did the focus group studies that flares, participants reported some as being sort of major flares, big flares, severe pain flares, and then others were sort of little blips that they could live with. And I think we would focus more on like a major pain flare next time.
I have 2 comments. I think it was very interesting to see how you systematically are investigating factors that can influence flares. When you considered weather, in your abstract, you were very categorical. You said there is no evidence for weather, and you changed it very slightly.
That's very true.
in your conclusion on the slide, to
Yeah.
a minimal. But what I was going to say, I think it's very nice when we assess that, not everybody presents data that is negative. And I think that's an important point. I get the impression that weather doesn't have really that much effect. Do you do
Any
any
effect?
any effect? Well, minimal effect. But do you interpret that in another way? With the pollen, you did see. So if you compare the two, it looks to be a little bit more interesting with the pollen, and the idea that Vic suggested. I mean, that
Yeah.
could be something. I mean, think about allergies and things like that. I mean, that it's easy to explain.
Right. And we actually think that a negative finding is helpful in this situation too, because again, going back to the focus group studies that we did, we found that participants experience flares. They're unpredictable, and they start to develop narratives around that. So it must have been this that I ate this morning, and that's what triggered it. And we found that it also came with a certain amount of guilt. You know, I was bad, I ate this, and I gave myself a flare. So they were trying to develop hypotheses and sort of taking those, which I think brings a sense of control, but at the same time, they were living with all these limitations that are probably not limitations that they need to live with. Like they could eat all this range of things and it doesn't actually matter. So we thought that a negative finding was also important.
One last quick question. I'm sure there are other people here that are curious. What are you looking at for other factors?
For other factors, right. So we did look at diet. We were limited to, as I mentioned before, I embedded this study within the main MAP study. So I was given 5 minutes of participants' time, so we had to be very focused in what we wanted to look at. So we picked 17 dietary items. So typically, if we were doing this in a more thorough way, like a food frequency questionnaire would be about 130 items. So we narrowed it down to the ones where we thought patients had reported most often. We looked at a few physical activities, so doing stomach muscle exercises. Actually, can't remember the other ones. Sexual activity. We did look at, I think, in symptoms of infection. Trying to remember. We published it a few years ago, but it was the same issue. Doing these population level analyses that we weren't really able to isolate the subgroups that were likely susceptible.
Thank you very much indeed. Thank you.
Thank you.